Good morning, everyone. I'll be talking about a paper on comparison of outcomes of Bowman stromal injury. So, based upon a lot of parameters like keratometry, pachymetry, vision, and clinical signs like scarring, in a patient of keratoconus, we have some options which include CXL, DALC, PK, intracorneal ring segments, stromal augmentation procedures for treatment. So in literature, there's a lot of articles available where only Bowman's layer or the anterior stroma is implanted after harvesting from a human donor cornea or a smile lenticule. And all these studies have shown stabilization of ectasia. We had also published a similar article where the Bowman's layer and the anterior stroma was harvested from the human donor cornea and injected in the recipient pocket with the IOL injector. So in this technique, with the use of a femtosecond laser, the Bowman's layer and the anterior stroma is harvested from a human donor cornea, and a femtosecond assisted pocket is made in the stroma of the recipient, after which this inlay is injected with the help of an IOL injector. Similarly, there are a lot of articles available on cross-linking as well, which talk about the procedure in thin corneas and the various modifications. But in the literature presently, there is no article which compares both the procedures in the same patient. So we thought, why not cover up this lacuna and cover both the procedures to compare their outcomes of both the procedure, which is BSI and CXL, in patients of progressive keratoconus. So we conducted this study, a retrospective study of non-randomized comparative and interventional case series of 5 patients with progressive keratoconus from 1st October 2018 to 30th April 2022 who had undergone BSI in one eye and CXL via the Dresden protocol in the contralateral eye. The minimum duration of follow-up required was 12 months after both the surgeries. And the data was retrieved to the EMR, where we collected information pertaining to demographic information, clinical features, and topographic parameters at 3 months, 6 months, 12 months, and yearly afterwards. The inclusion criteria was that these patients undergone either procedure in contralateral eyes with a minimum duration of follow-up of 12 months, and the exclusion was that they had not underwent any other surgeries like CXL earlier in those eyes. The primary outcome measure was to evaluate the changes in topographic parameters before and after intervention. So we found out that out of these 5 patients, the mean age was 20 plus minus 4.1 years with a male-female ratio of 3:2 and duration of follow-up of 12 to 36 months. Mean was 21.6 plus minus 12.4 months. So we had compared these outcomes in 2 groups, which is the CXL and the BSI group. In the CXL group, there were 2 patients of stage 1 keratoconus and 3 patients of stage 2. And in the BSI, there was 1 patient each of stage 1, 2 and 3 and 2 patients of stage 4 keratoconus. So we found out that this is of the group 1, which is the CXL. These patients had a significant decrease in pachymetry, and the K-mean front and K-max were almost similar before and after intervention. Whereas in the BSI group, the K-max front and the K-max had decreased, mean K-max had decreased significantly of around 4 diopters. There was a significant increase in pachymetry and a significant decrease in asphericity, which was noted. And amongst both the groups, greater flattening of K-mean front and K-max was seen in these patients when undergone the stromal augmentation procedure. So in these graphs also, we can see that after CXL, before and after CXL, the K-max is almost similar, whereas after BSI, the K-max decreases progressively for 6 months, after which it stabilizes. Whereas for pachymetry, after BSI, it gradually increases for 6 months, after which it stabilizes, and for BSI, it decreases for 6 months, after which it stabilizes. These are the pentagam of a patient of longest follow-up of 6 months, whereas in the sagittal curvature map of CXL and BSI. And this is for the pachymetry maps, where we can see an increase in pachymetry. This is the post-op photographs at 36 months, where no interface edema, haze, or scarring was seen. The strength of this study is it is the first study to compare the stromal augmentation procedure with CXL. It is done in the contralateral eye of the same patient, so there are minimal confounding factors. Whereas smaller sample size, shorter follow-up, and retrospective study, nature of the study is a few weaknesses of this study. But this gives us a future scope of doing a prospective study with a longer follow-up to validate the results of the present study. So in a nutshell, although both the procedures, they act through different pathways and both of them are comparable in stabilizing ectasia, a more favorable corneal topography was seen in this study after BSI, and this increase in pachymetry can also help in delaying or avoiding keratoplasty, or we can do CXL later on if the progression is noted. Okay, thank you.
Yeah, nice presentation.
Thank you.
I had two quick questions for you. The first is the Bowman's implant that you have done is in advanced ketoconic eyes, right? So those who could be cross-linked, that eye was cross-linked, and the fellow eye, which could not be cross-linked, underwent the Bowman's implant. That's what I understand.
Initially, yes, but afterwards we had done this in the stage 1 location. In stage 1 and 2 keratoconus patients also we have done the BSI.
Let's not consider that.
Okay.
I'm considering the cases which were advanced when you did the
Right.
Bowman's graft. So when you do the procedure, do you also consider the presence of apical scarring and striae, because advancement of keratoconus happens in 3 respects: the ectasia advances, the striae advance, and the scarring advances. So this set of advanced keratoconus seem to have advancement only in the ectasia, no significant other two, apical scarring or striae. So how often would you get a group like that to be able to do this procedure successfully?
So initially, like, we had started doing this procedure in patients with advanced also, but we came up with this idea because we realized that we with patients in which CXL cannot be done also benefit from this, and then patients where CXL can be done also benefit from this procedure. So these are those 5 patients who had undergone the procedure in contralateral eyes.
No, I'm telling you that
Yeah.
all advanced keratoconus, it may not be possible, to do the BSI when there is significant other changes like scarring. The earlier group, I agree, but
Right.
the later group, you seem to have had a lucky set of patients who had just the advancement in the K, but still nothing to preclude you from doing the treatment.
Okay. But we have done it in few patients who have scarring as well, actually.
Okay,
And they have been
that was
doing
not
well.
an impediment, they did
No.
well. Okay.
Yes, ma'am.
Okay, that's the point I wanted to ask.
Yeah.
Like if you have CXL, which is ethically a well-established procedure with an experience of more than 2 decades,
Yes.
while Bowman's transplantation, I think there is a chance of interface haze and interface scarring. Is it ethically correct, or is it okay for you?
So we have been doing the procedure from last 4 years, and in these patients, like I showed in the photographs, not till now, we have not seen any interface haze or scarring.
Okay. I think the best corrected visual acuity, was there any drop in any of the patients, even though your sample size was quite small? I thought it is somewhat comparable.
It was comparable, so there was no drop, and there was improvement in visual quality actually. Just share it again. In the CXL group, the best vision, the BCVA was almost similar, and in here also as well, 0.54 and 0.51.
Okay.
Any biomechanical analysis was done on these groups?
No, sir.
Right, thank you.
Okay, thank you, sir. Thank you.
While the next person is setting up, Dr. Maskati wanted me to make an announcement that all of you log into the app also. Just opening the app does not open you up to all the facilities of the app. So only when you actually log in, you're able to utilize the app much better. So please log into the app and don't just open the app to review what is there. Thank you.
Good morning, I'm Dr. Meghna. I'll be presenting our study of corneal topographic and biomechanical parameters in subclinical and form fistic keratoconus. I'd like to acknowledge all my co-authors. I have no financial interest. As described by Henrique et al. And the definition taken in our study, subclinical keratoconus is an eye with either topographic signs of keratoconus or abnormal slit lamp examination and keratoconus in the fellow eye, whereas form fistic keratoconus is an eye with both normal topography, normal slit lamp examination and keratoconus in the fellow eye. According to Gomez et al., True unilateral keratoconus does not exist, and ectasia can occur due to biomechanical weakening of the cornea. Ambrosio et al. Had longitudinal data showing that over 20% of the fellow eyes in unilateral keratoconus patients progress to clinical keratoconus, hence proving that normal topography does not exclude mild or early ectatic corneal disorder. Our primary objective was to evaluate the corneal topographic and biomechanical parameters in subclinical and formfistic keratoconus and in normal eyes. Our secondary objective was to identify parameters of significance in early detection of altered corneal biomechanics to supplement the diagnosis of early ectasia in instances of diagnostic dilemma prior to refractive surgery. Our study was a cross-sectional observational case-control study done over a period of 12 months. Our inclusion criteria was 31 eyes of subclinical and formfistic keratoconus and 44 eyes of normal subjects. Clinically diagnosed keratoconus, eyes with corneal scars, and eyes with prior ocular surgery were excluded from our study. We evaluated 16 pentacam parameters, 15 Corvus ST parameters, and 5 Cirrus parameters with corneal tomography, pentacam and Cirrus, and corneal biomechanics Corvus ST. Statistical analysis was done using the student's t-test. Area under the curve was calculated. Optimum cutoff values were determined using the Jordan's J cutoffs, and correlation was done using the Pearson's correlation coefficient. As you can see, the demographic data in the study, normal as well as the case group, were similar. This is a summary table showing the important parameters from pentacam, Corvus ST, and Cirrus, and the respective cutoff values, the sensitivity and specificity. This is a pictorial representation showing that posterior elevation bad from pentacam, TBI from Corvus, and symmetry index back from Cirrus, having were significant parameters with area under the curve more than 0.75. In this, the parameters highlighted in yellow, they have an equivocal sensitivity and specificity. These are the parameters from pentacam, these are the parameters from Corvus, and these are the parameters from Cirrus. And these parameters, they can be used in cases of diagnostic dilemma for diagnosing early ectasia. These are our correlation results. As you can see, the TBI correlated very well with the significant parameters of pentacam in cases as well as controls, whereas CBI only correlated very well in cases, hence proving TBI to be a superior parameter than CBI. Our study results were in concurrence with the study conducted by Dr. Ko et al., in which we found that deformation amplitude ratio, integrated radius, and CBI, they all correlated negatively with anterior radius of curvature, posterior radius of curvature, and thinnest corneal thickness, which were derived from the pentacam maps, and SPA1 correlated positively. These findings, they support the possibility of developing a biomechanical stage-based staging in combination with tomographic indices for detection of early ectasia. I would like to explain an example of one of our patients. The left eye of this patient is clinically diagnosed keratoconus. As you can see, this is the right eye map. The 4-map refractive pentacam map shows a normal looking topographic map with normal K values. The cornea is slightly on the thinner side, and on the right side, as you can see, the red parameters, that is the ART max, the PPI average, the bad, and other parameters point towards the suspect cornea. Similarly, the TBI and the CBI are in the red, again pointing towards the suspicious cornea. The Cirrus parameters of keratoconus screening also point towards the suspect cornea. This is a summary table showing that all the values of this patient are higher than the cutoff values proposed in our study, again pointing towards the suspicious cornea. In conclusion, I'd like to say that TBI with a cutoff value of 0.59, bad with a cutoff value of 1.8, and symmetry index back with a cutoff value of 0.16 are the best parameters from our study. Correlation results prove TBI to be superior. And whenever there's a diagnostic dilemma, we can use parameters with higher sensitivity and specificity to supplement the diagnosis of early KC. Thank you.
Yeah, very nicely documented. But not to put a point on it, but what is new in this? We already know that TBI is probably the only available holistic, tomographic parameter. We also know that if Corvus, if abnormal, is seen mostly in cases and not in subclinical cases. And as an institute, it's probably possible for you. It's an overkill for anybody to have the cirrus and the pentacam values all together in one patient. So since we already have TBI and CBI as established parameters, what value are you adding with your paper, except for definitely the, the way in which you have rehashed everything?
Yes, ma'am. Ma'am, the correlation between TBI and CBI has not been done before. So we had correlated correlated TBI and CBI with the significant pentacam parameters, and according to which we found that TBI was superior. Also, we followed up the study of Dr. Ko, in which they wanted to bring up a classification for subclinical keratoconus based on the classification of keratoconus, in which ARC, PRC are taken into account. Similarly, that is why we correlated all those deformation amplitude integrated radius, so that we can go towards a staging for subclinical, because it is a gray area still. So all our parameters which were significant, we had correlated with ARC, PRC and TCT, which was not done before.
So if you want to come up with something as extensive as this as a classification, don't you think it is more important to factor in normative data also, because we know even in our country between ethnic races there is a lot of difference. So I feel that by hair splitting into so many things, you'll probably miss the bigger picture, because then you put in all this that may be normal for, especially when you're looking at the subclinical cases, that may be the way the cornea is made for somebody, and we're not factoring in the normative data may lead us to erroneous conclusion, is what I would think. So nice in principle, but I think it needs a little more, thought and development.
Yes, thank you.
No comments.
See, the CBI is a non-linear index.
Yes, sir.
So to classify it would require a different
to be
index
converted to
altogether.
a linear,
Yeah,
yes,
in a
sir.
linear
Yes,
index.
sir.
So that was not brought out if you are thinking about that. And as ma'am rightly said, that nothing extra was brought out.
Yes.
Thank you.
Thank you.
Good morning to one and all. Today I will be presenting a rare case series of patients with coexisting keratoconus and pellucid marginal degeneration. 10% of pellucid marginal degeneration has been reported to be associated with keratoconus, but the characteristics of such patient is yet to be reported. We set out to do exactly the same to study the ophthalmic characteristics and treatment outcome of patients with coexisting pellucid marginal degeneration and keratoconus. Our diagnostic criteria was as follows. It was mainly a clinical diagnosis, a slit lamp biomicroscopy showing the presence of two areas of thinning, an inferior thinning suggestive of pellucid marginal, along with a central thinning suggestive of a keratoconus, along with clinical features suggestive of keratoconus such as flechures, forks, and stromal scars. This thinning was also documented using Scheimpflug image and ASOCT. Topographic features were studied but not included in the diagnostic criteria. Hence, a retrospective analysis carried out between 2016 to 2022 included 7 eyes of 5 patients and with a mean follow-up of 1.6 years. The mean age was 37 years with a male predominance, and all the cases were mostly unilateral, with the contralateral eye showing the presence of keratoconus. But the keratoconus features were present in all these eyes, and all eyes showed an inferior band of thinning, which was documented using slit lamp, Scheimpflug as well as ASOCT. I will be showing only 3 cases in the interest of time. This is a patient who had a central stromal scar, vogue striae, flechures, and a conical protrusion in the center, along with an additional inferior thinning. This thinning, 2 areas of thinning in the center as well as in the inferior is documented in Scheimpflug as well as in the anterior segment OCT. This is the topographic feature which does not fit into any typical appearance, which shows an irregular astigmatism with posterior elevation. However, the contralateral eye showed features of keratoconus, and on Scheimpflug imaging did not show an additional thinning. This patient in the affected eye underwent DALC with a large diameter graft and did well in terms of visual outcome, which improved to 6/9. Coming to our next patient, he had a central stromal scar with thinning and an additional thinning inferiorly. The Scheinflug image shows an conical protrusion with central thinning as well as an additional inferior thinning. The ASOCT clearly shows the stromal thinning and scarring in the center as well as an additional inferior thinning. The topographic features again do not fit into anything in particular, and the contralateral eye showed the feature of keratoconus. This patient underwent a penetrating keratoplasty followed by a development of cataract, for which he underwent cataract surgery with intraocular lens implantation. A large diameter graft was used in him as well. He was 44 years old. This is an interesting case in which in the left eye she had a conical protrusion with central thinning as well as an additional inferior thinning. It was a very advanced disease in the left eye, whereas in the right eye the thinning in the center was subtle but the inferior thinning was also noted. In the advanced disease eye, the inferior thinning was noted to be 255 microns. Hence, we went ahead and did a sclerocorneal intralamellar keratoplasty to stabilize the eye initially, followed by a corneal collagen cross-linking of the central cornea 10 months post-operatively. Having noted the inferior thinning in this eye, the other eye was cross-linked using a wide diameter beam with periphery also being cross-linked with imbus protection. This is the topographic feature of this patient, which again does not fit into anything in particular. Irregular astigmatism with posterior elevation of the more affected eye, and this is the contralateral eye, again does not fit into anything in particular. Since we did a sclerocorneal lamellar keratoplasty, she did not do so well post-operatively visually. Visual outcome was poor compared to the keratoplasty patients, and she was advised to use contact lenses. So keratoconus with pellucid marginal degeneration has been reported way back in 1984 itself, where PMD cases have been noted to have keratoconus in the central cornea. And in a large retrospective case series by LV Prasad group, keratoconus was seen in approximately 10% of the patients with PMD. They also reported a male predominance and a weak association with allergy, as we have also shown. And in a large national survey of pellucid marginal degeneration in Japan, the contralateral eyes of the patients with PMD had, in whom topography was available, was suspected to have keratoconus. And as all our unilateral cases were associated with keratoconus in the other eye, and our topography pattern was not used in the clinical diagnosis, and coexisting PMD will be missed if we rely only on our topographic pattern, and the diagnosis, we stress again, is mainly clinical. So what is in the name? Is it keratoconus PMD related degeneration? This is a paper by Bellin et al. Which clearly shows the Scheinflug image of a PMD on the right, and it also shows how it is difficult to differentiate between a PMD and an inferior keratoconus in the left. And we do agree that we cannot say for sure whether it is a PMD or inferior keratoconus, but what we recommend is a large diameter corneal transplantation in such cases, not to miss the additional thinning inferiorly, and to early cross-link the other eye, the contralateral eye, and not to miss the periphery in this in the cross-linking process. The limitation of our study is that we used the oculizer allegro system, which does not give more than 9 mm in diameter map, and we were limited by this, but our system does not give a 12 mm diameter pachymetry map. And in conclusion, PMCD can coexist in a patient with keratoconus, so it is vital to include all the areas of thinning while planning a corneal transplantation in such cases. Thank you so much.
Yeah, very nice and interesting. For me, the last couple of points I would consider the most important. So, hanging on to that, you spoke about PMD,
Yes,
and you spoke about keratoconus and PMD coexisting.
Yes, ma'am.
There is another small but sure entity called pellucid-like keratoconus.
Yes, ma'am. But
I
yes,
have not finished my question. Can I?
sorry.
So I know you're brimming with recent knowledge, but also, in the interest of the audience, these three are not, distinct entities. They have a lot of overlap. But pellucid-like keratoconus, since you wanted to tell, can you tell me how it will be different from keratoconus associated with pellucid?
So ma'am, in our topography pattern, actually the axial curvature map, if you see, it just shows an irregular astigmatism. It doesn't show the typical crab claw appearance So if you see a crab claw appearance, we
Only
cannot.
the crab claw appearance
Does
is the
not-
least important in the whole of the diagnosis.
Yes, ma'am.
So what else will tell you whether it is, because the ball game changes when pellucid is associated with keratoconus. For the simple reason that you said, you need to treat the center, you need to treat the periphery as well. Okay, because you need to address the thinning in both the places. It could be starting from the contact lens fitting has to be a wider lens. If you're cross-linking, it has to be a wider area. If you're doing a surgery, it has to be a wider zone when both the diseases coexist. Whereas if you have a pellucid-like keratoconus, then you're only interested in the area of the cone and a little beyond for the treatment. So how will you distinguish between the two?
So even in our study, ma'am, topography pattern was not included in the diagnosis. We mainly based it on the Scheimpflug and the ASOCT. Probably a limbus to limbus ASOCT could pick up an inferior thinning as well, which would help. And even a slit lamp biomicroscopy was the most important part of our diagnosis.
Totally agree, because the presence of Vogt striae tells you that keratoconus is there.
Yes,
But how will it matter to you whether, or how will you find out whether it is only keratoconus which is masquerading as PMD? You touched upon it. If you have a larger Scheimpflug tomography image, you don't confine yourself to that 9 millimeter. In 9 millimeter, the keratoconus will show, the inferior keratoconus will show as inferior thinning only. You may make the mistake of thinking it is a PMD, whereas in fact it is an inferior keratoconus. Whereas if you take a 12 millimeter map, if it is a true keratoconus, the thinning stops around that 9 millimeter area. Beyond that, not much problem will be there. Whereas if it is a keratoconus associated with the PMD, you get the bell sign. You showed that bell sign
Yes,
also
ma'am,
over
right.
there. You get the bell sign.
Yeah.
So that is one of the factors which helps you to distinguish between the two. Also, when you have both coexisting, the aberrations tend to cancel out each other. So
Okay.
for such a difficulty where two disease processes are coexisting, the positive and the negative aberrations may actually cancel out when you see the aberrometry. The importance lies in distinguishing the two, because whether to treat the center alone or including the periphery depends on this diagnosis. I agree it can be blurred at times. Sorry for the long.
Thank you, ma'am.
Yeah, it was a good presentation,
Thank you,
Anthony, but as Madam, I can't emphasize the point even more. You need a limbus to limbus coverage of the topography to make a diagnosis. Then other small query I have is that whether the quite a few cases of keratoconus, you'll be having that subtle anterior stromal scarring. So that can give the appearance of thinning of the
Yes.
cornea. No? So is it real keratoconus or is it scarring?
Difficult to say, sir, but in all our patients, they had Vogt striae and the fleisures, which was very typical of
Yeah.
clinical features were very typical. That is the only reason we
fine.
included the.
Fine. Thank you.
Thank you. Thank you so much.
Good morning, everyone. We have conducted a retrospective study to evaluate the efficacy of collagen cross-linking for progressive keratoconus in pediatric population. Coming to the introduction, keratoconus is a progressive corneal ectasia with onset typically occurring in adolescence or early adulthood. Decreased mechanical corneal stability plays an important role in the progression of ectasia, resulting in impairment of visual acuity with irregular astigmatism, progressive myopia, corneal thinning, and scarring. Progression of the disease can be dramatically faster in children with visual impairment, inability to obtain satisfactory correction with spectacles, and intolerance to RGB lenses. An inverse relationship is found between patient age and disease severity. In children, the progression of keratoconus can be both rapid and devastating. Younger patients have a higher likelihood of requiring corneal grafting surgery. So CXL was introduced to stabilize progressive keratoconus to prevent some of the underlying pathophysiological mechanisms and to avoid the need for keratoplasty for advanced cases. Aim of the study: to evaluate the efficacy of standard CXL for progressive keratoconus in pediatric patients and assess the halt or slowing of progression of ectasia and their effect on visual outcome. So coming to materials and methods, this retrospective study was conducted in a hospital in 74 eyes of 42 patients in whom keratoconus progression was observed in the preceding 3 months over a period of 2 years. Inclusion criteria being 18 years or younger patients who were showing signs of early or moderate progressive keratoconus. CCT of at least 400 microns at the thinnest point. Exclusion criteria being advanced keratoconus with stromal scarring, CCT of less than 400 microns, corneal eye drops, severe dry eye, corneal infections, and prior ocular surgeries. Preoperative keratoconus progression was confirmed by serial corneal topographies. Keratoconus progression was assessed by increasing Kmax value by greater than 1.5 diopters or more in 2 consecutive topographies within 3 months, pachymetry greater than or equal to 5% decrease in CCT within 3 months in 2 consecutive topographies, and change in myopia or astigmatism of at least 3 diopters in the previous 3 months. All included patients underwent CXL by standard residence protocol. Subsequent follow-ups were done on postoperative day 1, day 3, and on 1, 3, 6, 12, and 18 months respectively. IOP measurement and slit lamp evaluation with particular focus on atopy and allergic eye diseases was done in every visit. Changes in simulated keratometry values in the flattest meridian K1, steepest meridian K2, Kmax in diopters, topographic astigmatism, manifest refraction and spherical equivalent MRSC, uncorrected visual acuity, best spectacle corrected visual acuity in logMAR, and central corneal thickness were analyzed to evaluate the effect of CXL. All data was reported as mean plus or minus standard deviation. The paired t-test was used to evaluate the difference between pre and post procedure values, and p less than 0.05 was considered as statistically significant. So as we can see from the results table here, the UCVA, BSCVA, and MRSC values improved statistically over a period of time throughout the entire postoperative period, compared to preoperative values. And both UCVA and BSCVA improved significantly during the first 6 months after CXL itself, and this was maintained over the post-op period till at least 18 months in most of the patients. So coming to the topographic indices table. So as we can see in the topographic indices, SIM K1, SIM K2, and Kmax, they showed an initial worsening, probably because of epithelial debridement, and there was these indices showed a slow but statistically significant improvement over a period of time, probably due to reepithelialization and collagen remodeling, and this was maintained throughout the entire postoperative period in the most of the patients that we followed till 18 months. So coming to the discussion part, this study was performed to investigate the efficacy of CXL for progressive keratoconus in children and adolescents and the progression during clinical follow-up. Refractive and topographic indices show the slow but significant improvement indicating flattening of the ectatic cornea. Central corneal thickness showed a faster recovery in our patients, although P was not statistically significant here, suggesting a faster and more effective healing process in the younger eyes. Sterile infiltrate was seen in immediate post-op period in 4 patients, which was medically managed. Haze 1+ was seen in 3 patients after the procedure, which was medically managed by topical steroids. 31 patients underwent CXL procedure in both eyes eventually, as they showed keratoconus progression due to associated atopy or allergic eye disorders. Progression after CXL was noted in 4 eyes who had a history of extensive eye rubbing. Repeat CXL was performed in these eyes at the end of 1 year follow-up. Stabilization of progression was noted at the end of 6 months follow-up. So coming to the conclusion, CXL procedure for progressive keratoconus in children and adolescents has a safety profile similar to the one that's seen in adults. The effect of CXL might not last as long as in adults, and we recommend a careful follow-up to detect a decrease of the CXL-induced effect. A study investigating the long-term effects, probably greater than 5 years, is needed to clarify the eventual progression of keratoconus. Our clinical experience has shown that the progression of keratoconus in children can be dramatic, with a significant visual impairment accompanying the rapidly developing corneal ectasia. We recommend not waiting for documented progression in children and adolescents. Once the individual risk-benefit analysis is done and legal guardian have received adequate information and enough time for consideration, legal consent taken, treatment should be started as early as possible. The recognition of early progression is a key aspect. A tight follow-up schedule with serial corneal topographies is needed to identify those eyes that deteriorate rapidly. The procedure, when performed early, may eliminate the need for penetrating keratoplasty in advanced cases. The optimal timing of intervention, however, is debatable, with some authors suggesting cross-linking at the diagnosis of keratoconus without awaiting for disease progression. So I conclude that prevention is better than cure in pediatric patients, and to prevent and to protect is better than to repent and to repair, as we have seen in progressive keratoconus in pediatric patients. Thank you.
Nice presentation. What kind of protocol was followed for cross-linking?
Sir, it's mostly, it was decided on serial topographies, which was done for patients who have presented to us, and the refractive error that has been seen in the, like,
What is it, Dresden or accelerated?
Dresden protocols. So a standard Dresden protocol was done. So if a pediatric patient has present, normally first from the scissors reflex and refractive error only, we can see if the patient is having any astigmatism. So if the patient with any person who is having more than 1.5 diopters, we normally recommend for a topography.
So in your series,
yes.
how many patients of pediatric keratoconus did not progress?
So we have taken those patients who have progressed, and some patients did not show progression in one eye, some have shown progression in the contralateral eye. So mostly patients have, we have taken those cohort of patients who have showed serial progression. Say one eye was done first.
Do you find any difference of any inflammation in both the people who were more inflamed were more progressing more?
Yes,
or
sir.
did you
Yes, sir.
Did you
Mostly,
control the inflammation and still found
yes,
progression?
sir. In spite of, if the patient is in active inflammation, obviously we cannot take them up for the procedure. We obviously will.
So what protocol was followed for that?
Even after giving medical management with antihistaminics and all, after waiting for 1 month or maximum 3 months, we do repeated topographies in every visit of say 2 weeks or 1 month. In spite of that also, they are showing progression. And in the end of 3 month follow-up of a particular patient, they are showing topography, there is progression, more than 1.5 diopters, or CCT is falling more than 5%, and the refractive error is also showing changes. Then for such cases,
how long is your follow-up just now?
Actually, we are taken till 18 months, but not all patients have come. But till 12 months, many patients have reported us for follow-up.
Fine.
Okay. So while treating allergy, you made sure that the symptoms have come down and the.
Yes, sir. I mean, we cannot do in active inflammation. So, till the allergy is controlled, and we obviously advise the patient not to rub the eyes more and all.
Yeah,
but,
no, because the inflammatory cytokines definitely have
definitely. After that is controlled, under the this medication of antihistaminics also, this patient, this procedure was taken. In spite of undergoing the CX procedure also, in post-op management also, antihistaminics were continued for the patient. We have not stopped them.
Okay.
Because
One another thing, I just want to know, like in pediatric population, like it was under general anesthesia or?
No, sir, local anesthesia, sir. So our youngest patient being 11 years, and they were
local or?
Local anesthesia, sir. I mean, sorry, topic, not topical, sir. I mean, block, sir, not general anesthesia.
Okay. So, like children, obviously, we expect them to move their eyes around, even in
sir,
adult.
under peribulbar block, we have done, sir.
Oh, was it?
Peribulbar block.
Okay, fine. Yeah, one more thing in the discussion, have you put any studies?
Sir, yes, sir. I have put in, sir.
I didn't, it was there, it was compared to the other studies?
Yes, sir. There is one study of Insegura and one of Chatti, sir. And
Yeah,
both
sure,
of
sure.
them
Okay,
have said ki it's better that we go for pediatric population, it's better that we go for a C3R procedure rather than wait, because many of the studies say that we can wait till 1 year for till the Kmax is progressing, till 1 year you can wait. But given the pediatric scenario, it's better that we approach the patient and we do the CXL, because we never know that it will come back, or if they come back,
Yeah,
it
that
will come
point
with the
taken,
full
yeah.
clearance.
Yeah, that part I agree. Thing is, Vernal is very common in pediatric population, so VKC needs to be controlled. Post-operatively is not that much of a problem, because your steroid which you're giving for the CXL quite often takes care of the allergy.
Yes.
In fact, patients are very happy that the child is not rubbing the eye and they don't realize it's because of the steroid. And if there is a price for title, you will definitely get it. Prevent and protect better than repair and repent is awesome. Unfortunately, I don't think there is a category for title. Don't you think in pediatric patients, especially since there is this concept of collagen turnover and reduction in the procedure effect over a few years' time, in adults that may not be a problem because by the time the turnover happens, the age-related or 40 cross-linking happens, but in pediatric patients, that's one school of thought that collagen turnover happens, which mitigates the effect of the procedure over a period of time. In the light of that, do you think your follow-up is enough to justify what you're saying?
No, that's what I have also added in discussion.
You probably
that we
need
a
a
greater
much
follow-up,
longer
and
time,
we
though
are.
I totally agree with you that we would also err on the side of doing the cross-linking in children. Thank you very much.
Thank you, ma'am.
I think the next two people are not there, so it's Rohit on the podium. Followed by the first girl.
Thank you, everyone. This is a small study so as to compare the ICL and LASIK in a cases of a high myopia. The refractive surgery, it has come a long way. In the initial days, even for a high myopia, once the parameters were suitable enough, we were planning for a excimer treatment. But in last few years, the ICL has taken up, or any sort of phakic has taken up as a replacement to an excimer procedure. So there is no financial disclosures as such. The purpose would be to compare the results of LASIK and ICL in a correction of a high myopic eyes and to look for safety and efficacy of both the treatment modalities in a high myopia. How did this study go about? It was a retrospective study. It was a 559 eyes that underwent LASIK and 210 eyes that were subjected to ICL that were taken under the study group. The patients were examined serially and all patients had a follow-up of more than a year post-operatively. The mean baseline myopia was slightly higher in the ICL group, which was in the range of minus 9.8 diopters plus minus 1.7 diopters, while in a LASIK eyes, it was minus 9.1 diopters plus minus 0.97 diopters. Topography was done in all the patients and only suitable patients were taken up for LASIK and ICL, assessing their suitability in terms of pachymetry and antechamber depth. So, suspicious topographic eyes were counseled for ICL and an internal antechamber depth of more than 2.8 mm was strictly followed in eyes which were to be taken up for the ICL procedures. So what were the ultimately results that we have seen? 100% of the eyes in ICL group and 71% of eyes in a LASIK group were within plus minus 1 diopter of targeted correction at the end of 6 months post-op follow-up. Every index of best corrected visual acuity, uncorrected visual acuity and stability of refraction studied favored ICL over a LASIK procedure. And a FACT or functional acuity contrast test remarkably showed better results with ICL as compared to LASIK. If we look at a line diagram, you can see that how the contrast has been affected. The blue line shows the ICL and the red line shows a LASIK procedure, the eyes that underwent a LASIK. And you can see the contrast sensitivity was very well maintained, or it to an extent improved in a patient who had undergone a ICL procedures. While in a LASIK, it gradually dipped more at 1 month, then it again improved at the end of 1 year. However, it still remained less or diminished to compare to what it was preoperatively. At 6 months follow-up, both the loss of 2 or more lines, that is LASIK 2% and ICL 0%, and gain of 2 or more lines. In ICL, 7% of the eyes, and in LASIK 3% of eyes of a best spectacle corrected visual acuity were better with ICL as compared to LASIK. The efficacy outcomes were better with ICL, with a predictability of ICL being 90% as compared to 76% with the LASIK eyes. And none of the patients had any post-LASIK ectasia at a 1 year follow-up in a LASIK group. However, I definitely agree that this is a very small time frame that we are looking at to study for the post-LASIK ectasia. Just to again compare in a graphical manner the efficacy outcome and a UCVA or uncorrected visual acuity attaining a 20/20. You can see that the blue line shows the ICL eyes and the light blue eye shows the LASIK eyes. The efficacy outcome was somewhere around 75% in a cases of a LASIK, and it was close to around 90% in a cases of a ICL. And the number of eyes that could attain an uncorrected visual acuity of 6/6 or 20/20, those were around 35% only in a cases of a LASIK, and those were around 50% in a cases of a eyes that had undergone a ICL procedure. So in this highly myopic series, UCVA of 20/20 or better was 50% with ICL as compared to only 35% with a LASIK, as has been shown in the previous graphical depiction. The incidence of anterior subcapsular opacities that were seen in 7% of ICL implanted eyes, however, only 1% of those developed to visually significant cataractogenesis. So to conclude, the toric ICLs were superior to LASIK in terms of safety, efficacy, predictability and stability of refraction. FACT also favors ICL instead of a LASIK in a high myopic refractions. We conclude that ICL was safer and more effective than LASIK in a high myopic refractive errors, and ICL could be the treatment of choice instead of excimer in a cases of a high myopia. So in the literature that we had gone, the study that was conducted by Dr. Sri Ganesh, which compared ICL, LASIK and a femtolasic, or in short the SMILE, it also favored ICL in terms of a FACT, and similarly with the Sanders group who had looked for a cataractogenesis with ICL also showed that there had been anterior subcapsular opacities with a ICL, but the chances of those favoring progressing for any visually significant intervention were less. Thank you.
Nice presentation, Rohit. What ICL had you used? It was a V4C?
These were this study was basically in last 2 years or something, and in last 2 years or something, I think the Star Surgicals, what they are supplying or what they are providing, most of my...
Was it a center flow or?
It was with a center flow.
So the incidence of 7% of anterior subcapsular opacity is very, very high. With the center flow world over, such high incidence is not been reported. What could be the reason in your series to have such a high incidence?
I would say that rather 7% has been reported as a opacities in a lens, but then if you are noting that it's only 1% of the patients who had ultimately went ahead and required any sort of a visually significant cataractogenesis they had. So,
but that is just in a 1 year's time you have seen the progression of 1%.
Yes.
But 7% to report anterior subcapsular opacities, meaning the vaulting, post-op vaulting, how much was your vaulting in all these cases?
I would say that ideal vaulting, whatever we should actually see, it was not that they had a low vaulting or something which I would be worried about. Somewhere in the range of 400 to 600 microns or one corneal.
Still with the new center flow ICLs, even a 0 volt is not a problem. But having so many high opacities means, were they because of the visco you were using or the residues which were left behind, trapped between the lenses, whether they were pseudo opacities or lenticular opacities?
The very fact that I'm saying like what I was examining, it was at the end of 1 year that we were seeing. So unlikely that this could be related to the viscoelastic material, because it might be like getting washed off or something at this long period.
Okay. The only thing, ICL is definitely better visually because not altering the structure of the cornea at all. And the other thing which I wanted to know is the K values. In such high myopes, what were the pre-operative K values? Did you, in the LASIK group and the ICL group, it doesn't matter, but in the LASIK group, definitely it would matter.
One thing we had made sure, I had like mentioned that none of these eyes were any sort of any, like even the ICL eyes, these were not any form first keratoconus or altered topography as such. So
what I mean is, how many of these eyes were below 30 diopters or 35 diopters flattening?
Post-op after the excimer. Most of those eyes, like even we had done ablation in the high myopic age group, high myopia range, but then none of those eyes were less than 36 diopters at the completion of the procedure or 1 month topographic image.
Yeah, thank you, Rohit. See, this 71% only achieving 6 by 20 by 20 or 6 by 6 vision in LASIK, don't you think it is much less than expected? 71% in the LASIK group.
Yes.
You had a success rate that is
attaining
about
6
20 by 2, yeah, attaining 20 by 20 vision.
uncorrected.
Yeah, only 71% had it. Can you attribute any reason for that?
See, it's only that 2020 is having a 71% having a 2020, but then if you consider it as a plus minus 0.5 diopters standard deviation, then it might go up to even 90% or something. So those were the very high myopic eyes, like the average myopic range was around 9.1 diopters in a LASIK. So that could be one of the reasons.
How many were within plus or minus 0.5 diopters of spherical?
More than 90% were within plus minus 1 diopter.
Okay. Yeah. One more thing, when you compare the two groups, one group had around 559 patients, other group was 210. So the group, I think it may not be exactly a comparable group. Then, yeah, I think that's fine.
Yeah, good to see you on the podium again, Rohit. I am only rephrasing the questions by these two people, Dr. Anil and Dr. Vaishal. You spoke of a set of LASIK patients, I don't remember the percentage, who lost 2 lines of BCVA. Why did that happen? Why would somebody lose 2 lines of BCVA post LASIK? You had a small segment which
Yes.
said that BCVA was, I don't remember the percentage,
Yes.
but the best corrected vision was less by 2 lines post-operative. It's the best corrected vision. So
Yes,
why would
that
the safety of the procedure was quoted as 2 lines less than the pre-op? So why did that happen?
that was at the end of 1 month or something, and it could be because of some sort of being a high myopic ablation, and it was a
Phase
standard
formation.
microkeratome. So some sort of a dry eyes or something might be contributing to that I would attribute it to.
But there was no slit lamp or objective finding that you could correlate with the reduction in the vision in those patients.
Apart from SPKs or something, not
Nothing
something very
particular.
significant.
And then the question that he asked, did you use K as a measure? Of course, this I know that probably the groups were randomized or what, I don't remember. But in real practice, suppose a patient has adequate pachymetry to do a 10 diopter treatment or 11 diopter treatment. Would you be guided by the preoperative K? Because that probably is the norm. So for example, somebody has enough pachymetry but has got flatter K to begin with would be sent to ICL group, whereas somebody who had the same pachymetry but little steeper K can be considered for LASIK. Do you agree with that? Or I think that is the question that he was trying to ask.
Definitely, at the end of the procedure, we make it a point that yes, post-op case should not be flatter than 36 diopters.
So that will be also
One of the
included as a guiding
criteria.
factor. That's the point that he was trying to ask. Thank you.
Thank you.
Somebody has experienced. There are 2 patients of my ICLs who were amblyopia patients around 636 or 660, but post ICLs they suddenly improved to 6.9, and so we're having squint also. It was exotropia with amblyopia, and with pinhole vision also was not improving before procedure, before ICL to 636 and 660, both patients. And I had not given them any promise that their visions will improve by ICL beyond this. And both of them were minus 13 and minus 14 with some cylinders, I don't remember. But both improved to 6.9. This is one different thing which I observed, and I was surprised pleasantly. Does anybody else has got these experiences?
Yeah, it's not only that, the closer the vertex distance, the better the vision is for the patient. For a patient with 12 diopter myopia, the contact lens will give better quality and quantity of vision, and the intraocular lens, the lens inside the eye will give even better. So I think that is what is in play over here, unless I'm missing something. Yeah, I think, anyway, thanks for your input. So I think we have the first speaker who's become the last speaker now for the day. Yeah, Durga Lakshmi, please proceed with your presentation.
Good morning, everyone. So I'll be presenting on long-term outcomes of a laser-based cross-linking TREC and TCAT in patients with keratoconus. So the current management of protocols of keratoconus were established previously, where patients with keratoconus progression more than 450 micron pachy were treated with laser-based cross-linking. Patients with advanced disease require an ICRS or a keratoplasty. So what was known so far was that the manual collagen cross-linking had proven its worth for achieving stability, but there is no improvement in visual quality, and we had to rely on a rigid contact lens for the same. So which brings us to our question, can both of these qualities achieved in a single procedure. So many groups, including ours, have described this, the technique of simultaneous topo-guided PRK with a cross-linking and established the efficacy and safety as well. So how do we go about in a patient with progressing keratoconus with a thinnest pachy more than 450 micron? We can plan a topography customized ablation treatment based on the corneal wavefront as well as the ocular wavefront. The advantages and the safety profile was already known, but how do we proceed when the patient's topopachy or the thinnest pachy is less than 450 micron? So, and also when the stromal ablation exceeds 40 micron. If the ablation on corneal wavefront as well as ocular wavefront is very high, there is a risk of excessive tissue ablation as well as scarring in keratoconus patients. So we came up with a novel idea of topo-guided removal of epithelium in keratoconus, in where we perform a PTK at a depth of 10 to 15 micron more than the thinnest epithelial thickness. So how does a trek actually is planned? We localize the cone on anterior tangential curvature map. We identify the long and short axis. We perform a PTK over the area of thinnest pachymetry with 15 to 20 micron of stromal ablation. We manually remove 8 mm of epithelium around the cone, which is followed by an accelerated protocol of collagen cross-linking. So when the maximum ablation is very high with excessive tissue loss, yeah. So when the maximum ablation is very high with excessive tissue loss, we can ablate over the and a TCAT planning shows a very high ablation. We can actually ablate only over the steepest anterior tangential curvature point or on the cone area. So we observe that the postoperative outcomes in these patients have been good in terms of flattening of the keratometric topography, reduction in corneal astigmatism, and improvement in the best corrected visual acuity. So what were the benefits of TREC? Along with a minimal stromal ablation pattern, it was a tissue-saving procedure. There was regularization of topography, enhanced cosmetic lens fitting, as well as minimal change in the pachymetry. So first research question was, are the outcomes of TREC and TCAT comparable in terms of safety and efficacy? So according to our previous research, where we evaluated 1-year outcomes in 72 patients who underwent TREC and 74 who underwent TCAT, we noticed that interestingly, the improvement in visual acuity was similar, but TREC actually removed less volume of tissue. So our research question 2, what are the long-term outcomes of TREC versus TCAT? So after documenting progression on pentacam and examination of the epithelial mapping, based on the ablation plan, 170 patients underwent TCAT, whereas 200 underwent TREC on a Schwindamaris platform, followed by accelerated cross-linking. The efficacy profile of both TREC as well as TCAT in terms of UDVA and CDVA was similar. Just to go ahead, 40% of them gained 1 line after TREC, 55% showed no change in BCVA after TREC. The corneal astigmatism as well as refractive astigmatism reduction was similar in both the groups, as well as reduction in aberrations in terms of RMS coma and trefoil was better, better reduction in TREC than TCAT group, as well as a reduction in keratometry in TREC was better than the TCAT group. So few of the post-operative outcomes in some of our cases. To discuss about some of the complications, one 170 patient had a progression, while 2 over 200 patients in the TCAT group had progression, who were posted again for a recross-linking based on a Dresden protocol. There was excessive flattening 1% in 1% patient in TCAT group, and loss of lines in 2% in both TREC and TCAT at 5 years. So what was known basically was the 1-year outcome of TREC and TCAT was known, and we had seen that TREC had actually a lower tissue ablation. What did this study at? This was the first study to study the long-term outcomes, that is more than 5 years outcome. And TREC is comparable to TCAT in terms of visual acuity, and it is actually better in conservation of greater amounts of tissue, and is a viable alternative for patients with decentered cone as well as more advanced grade of keratoconus who underwent TCAT. Thank you.
Very nice and
Thank you.
impressive, Durga Lakshmi.
Thank
Actually,
you.
I learned more from this paper than I can contribute, because I was looking forward to knowing about the procedure in detail after reading your paper.
Yes, ma'am.
So I have 2-3 questions. My first question is about the name of the procedure. Why are you calling it topography guided removal of epithelium in keratoconus when you're actually ablating 30
Stroma
microns
as
of
well.
stroma?
Yes,
I
ma'am,
think the
but-
nomenclature is a little misleading, right? You can't contest that. Okay. The second is that the way I understand a PTG-PRK or
Yes,
a
ma'am.
TCAT procedure is that you work on flattening the steeper area. Not only
Correct,
that,
ma'am.
you need to also produce a coupling effect of steepening the flatter area.
Flatten area,
So
correct.
that is what contributes to the regularization. That part obviously is missing in TREC because you want to conserve
Only the-
tissue.
yes, only
so
the cone
then
area,
how can
yes.
you say that this works equally well, even though you've shown impressive
Yes,
results?
ma'am.
And lastly, if you have such a large number of patients over a long period of follow-up, then will TREC, if you answered my previous question, make TCAT obsolete? Why would we treat more when we can treat less?
Ma'am, in TCAT, basically, we are ablating the surrounding area as well, not only the cone, and it is causing more ablation of tissue, while as in TREC, we are...
I agree to that,
Yeah.
but it also is of an advantage. There's a reason for ablating beyond the cone in TCAT, which is to cause more uniform
But ma'am,
regularization.
in TREC patients, we are basically treating patients with a decentered cone. Like in a cretin protocol, we were treating a PTK, transepithelial PTK, which was a centered cone. In these patients, basically with an advanced keratoconus with a decentered cone, we are trying to treat.
So if this is working so well, then can it substitute or replace a TGPRK, means a TCAT procedure?
In patients with decentered cone,
Yes, you feel it
yes.
can. Okay.
Yeah, in TREC, you are ablating only 10 to 15 microns of.
Sir, apart from the epithelium,
Yeah.
around 15 to
No, but
20, maximum
epithelium-
20 micron of stroma.
Yeah, does it make a difference because epithelium will come back?
So epithelium will come back, and we have seen that the difference in the pachymetry was hardly anything, but in the pre-op as well as the post-op. So,
Yeah.
ma'am, the epithelium will.
Can you scientifically explain it? That's what we are trying to.
So, sir, we are just ablating 15 to 20 micron of stroma, whereas in TCAT we will be ablating more of stroma. But in TREC, we are ablating only over the cone area with a minimal tissue ablation as much as possible. Oh,
Can I, okay, I'll put myself in your shoes and try to answer that. You see if I've understood it correctly. So, actually the ablation is not much. The ablation
yes,
is
ma'am.
very little.
Stromal ablation, yes.
You've finished your turn to answer. It's my turn to answer.
Sorry.
So,
Yes,
when you have a keratoconus,
Yes.
which has a decentered cone, we know that epithelium serves its role of masking, and
Yes.
you have a decentered cone under it. So when you remove the epithelium and you ablate a little bit, you do not ablate too much, but the epithelium which reforms over it is not as variable as it was earlier, because you have flattened a little bit. Does that contribute to the success of your treatment? That's
It-
what matters than the actual flattening. The epithelial remodeling is
Yes, ma'am,
smoother.
actually,
So
yes.
it's not
In the-
correct. So that's probably what contributes to the success, but it's hypothetical because I've not done a check of my own.
Probably, yes.
That can only do by if you do a post-operative epithelial thickness later on. If we have a
We have to include the epithelial thickness as well, sir. Yes. Yes.
The other question coming is using adaptive fluence. Here we are just restricting ourselves to TREC for less than 450 microns. But if we could do TCAT for less than 450, would TCAT be better than the...
Sir, but in the TREC, we are actually measuring the cone, like the short and long axis of the cone, and ablating over that area only. In a TCAT, the area of ablation is larger, and that is why it will not be comparable to the TREC.
ठीक.
Yeah, that's it.
Thank you. Thank you. Thank you, ma'am.